this topic, which is beyond the rash and fever, the evolving phase of chikungunya. So this has come because month ago I've got a few patients with same clinical picture. So most of them have one of my known patients, she has come with a fever with severe arthralgia and myalgia. So they took her with the wheelchair, and then I have given the medicine thinking about the viral fever and asked her to do the foot blood count, CRP and other things as well, because we had to think about the dengue as well. And then on third day, her husband also came with the similar symptoms, and then husband told me that now the wife is getting the rash as well, and she has got the swollen joints as well. So then I have given him also the medicine, and then after about 7 days, both my husband and wife came and told me that now the daughter also has got the same symptoms. So at the same time, they were from Peradeniya area, and then there were another 2 or 3 known families came with similar symptoms. And then this thought came whether this could be chikungunya, because fever, arthralgia, rash, mainly like arthritis like picture. So then I had that suspicion and how to get the things done. So we will discuss during this discussion, because I would like to thank Tulani, because whom I just spoke to Mudita, because he's the microbiologist and known for me for a long time. So then he introduced me to Tulani, and then because of out of enthusiasm and so many patients came, we were able to collect some samples of acute phase as well as delayed phase. And acute samples she was readily agreeing to do, and we have done 9 samples, and out of 9, 7 got acute antigen positivity for the chikungunya. So it is the same pocket. And the other thing is that you know that when we are discussing this chikungunya, it is the same vector as dengue. But being in Peradeniya, we haven't got much number of patients with dengue infection on that particular village. So then we had a doubt how it happens, and then such a quick spread through the families also was a little question how it comes, because we have seen the dengue in families as well, but we have usually seen once the mother gets, so it's after a 10 or 14 days the next one gets. But unlike that chikungunya, it spreads very rapidly. So when I just browsed through the chikungunya articles, they said that it's a traveling disease and it's a rapidly progressing disease among the community as well. Okay, so I will give you the recent clinical insights, long-term challenges, and public health implications. Just for the formality, you all know this is arboviral disease caused by chikungunya virus. So usually you call it as chick virus, and it is enveloped spherical single-stranded positive sense RNA alpha virus. Chikungunya name derived from the Tanzanian language, that which bends up. So because of the severe arthralgia, patients tend to bend, and that says how severe the disease is, which is transmitted primarily by the Aedes albopictus and Aedes aegypti. There are 4 different genotypes: Asian, West African, ECSA means East Central South African variety, and Indian Ocean lineage variety as well. So these 4 genotypes are there. And regarding the history of the chikungunya, so it was first described in 1952 in Tanzania, and then there were several epidemics in other parts of the African countries as well. So then it comes to the Asia in 1958, initially identified in Bangkok, and then it has spread to the India, Sri Lanka, and other Southeast Asian countries as well. So in Europe, it was first reported in 2007. It was in Italy, and in America, it was in 2013, mainly the South American countries. So what about the Sri Lankan situation? So in Sri Lanka also, the first epidemic was reported in 1960s. And after many decades, it has re-emerged in late 2006. So when we were registrars, we have seen so many patients, and I had an opportunity to involve in one of the epidemiological and this clinical signs and symptoms study, which was done by one of my mentors, Professor Sam Kularatna. So we published some articles as well. So in 2006 and 2007, there were 40,000 cases, and then 2008 also there were 40,000. So it was also, we have seen that so many patients come from particular villages, and it has spread very rapidly with crippling arthritis as well. So after many years, once again from this late January onwards, we have seen sporadic outbreaks, mainly started from Colombo and then suburbs of the Colombo and then Kandy district as well. So regarding the 2024-2025 update, so it's once again seen in Asia, America, Europe, and African countries. Up to now, there were 80,000 cases identified, confirmed cases, and there were 46 deaths along the 14 countries. So chikungunya is not a deadly disease, even though it causes morbidity. Mortality is less, so the patients with so many comorbidities will succumb. So therefore, that is also, we have to keep it in our mind. So we have seen the local outbreaks, as I said, in Colombo, Gampaha, and Kandy districts. And these outbreaks are influenced by the climate change, urbanization, and the vector expansion as well. So often it is under-recognized due to the various clinical presentations, and as it has come with a many years silence. So because initially 1950s, later 2006, and now again in 2025. So there were so many gaps in between the disease outbreaks. So therefore, it is usually under-recognized, and there are overlapping symptoms with dengue fever as well. So this is a 2025 map. You can see the chikungunya countries with chikungunya infection. So it's in Asian countries, it's in African countries, it's in Europe as well, and the American countries as well, and some parts of the Western Australia or the this western part of the Australia as well. So regarding the cycle, there are two cycles. One is a sylvatic cycle, where usually this virus will be staying on small mammals, rodents, and sometimes the human get affected. And the urban cycle is the one which causes this epidemics or outbreaks. So where the mosquito to human being, and then you get the disease. Incubation period, it's typically varying from 3 to 7 days. So that could be the reason that once the mother gets the disease, father comes on the 3rd or 4th day, and the daughter come on the 7th day. Like, so that could be because it has a very short incubation period, but it could range from 1 to 12 days as well. And for the diagnostics, you need 5 to 7 days because you should know that the viremia will start for 5 to 7 days, which is really important during the diagnostics as well. So what about the clinical presentation? So it is a viral fever. So therefore, usually in acute presentation, patient comes with high-grade fever. So almost all patients had the febrile illness fever more than 100 Celsius, and it's with arthralgia and mainly arthritis as well. So regarding the arthritis, it's mainly the ankle joints and small joints of the hands and feet, and later they do get knee joint arthritis involvement as well. So the other striking feature was in 3 to 4 days time, they do develop rashes. So this rash, it could come on the face, arms, legs or entire body as well. Some do get the itchy rash, some do get non-itchy rash as well. This is, I will show you some pictures. They do come with severe headache, nausea, and sometimes diarrhea, chest infection features, conjunctivitis, and lymphadenopathy as well. So these are the rashes. So this is one of my patients. You can see that initially it looks like a little bit of acne, and then when it spreaded over the body, it was a maculopapular rash which was little itchy as well. The next one shows that involvement of the ankle joints with some discoloration. This lady was a very fair one, and she has got a hypermelanosis due to the chikungunya, and she has got the skin discoloration as well. And these are the other pictures of the rash that what we have seen with patients. So sometimes it could mistaken as whether this could be a measles infection. So we have seen whether patients has got Koplik spots, but they were not there. And then later on, they have developed the full-blown chikungunya picture. And these are some pictures of joint swelling. You can see the involvement of proximal interphalangeal joint as well as distal, mainly the hand arthritis and arthropathies they could get. And then during the convalescent period, or once they get better from the fever, these patients, they used to come with this rash. So mainly the hyperpigmented rash involved in the nose area, which causes as which called as chick rash as well. So when they come with this rash, they were free from fever, and joint swelling and joint pains may persist, but joint swellings also have gone. And in fact, there were some patients who worked in Colombo and who have come here because of the fever and other things. They have told that, okay, in my boarding place, we have got 5 or 10 people were there. All 8 or 9 people have got fever with arthritis, and they were confirmed at chikungunya, and they all had got the rash, and they were asking me whether I also have got this nasal discoloration. So luckily I haven't got. Then I just show the patient, no, you are also getting now. So initially it comes with the either sides of the nose, and then later on it will be spreading. So then they were so upset as well, because it causes the disfigurement as well. So then they will really get upset as well. There are atypical presentations. So typically we do get, as I said, fever, arthralgia, rash, but there are atypical presentations with neurological sequelae like encephalitis, and sometimes post-infectious Guillain-Barré syndrome you can get. Myocarditis, so basically you will see the ECGs, arrhythmias, they will get the ECG changes, and the shortness of breath as well. Most of the patients shows the liver involvement with high SGPT-OT levels, but they were not go beyond 500. So mainly it is confined to the hundreds to 200s. But there are some patients with mainly the hepatic involvement, renal involvement. It could cause acute tubular involvement or acute glomerulonephritis like conditions. Due to the lung involvement, you can get pneumonia, pneumonitis, and ARDS as well. So this picture summarizes, apart from fever, arthralgia, where else this chikungunya can affect. So from eye, you can get keratitis, uveitis, episcleritis. For the brain, encephalitis, and mainly the encephalitis and myelitis. Rest of the CNS, GBA is the main thing. Apart from that, we have seen the patients who are getting a little bit of depression and psychosis as well. For the heart, as I said, myocarditis commonest, and they do get arrhythmias. Renal manifestations are acute interstitial nephritis, acute glomerulonephritis, acute tubular injuries, and they can go into acute kidney injury as well. GIT, due to the GIT involvement, they do get diarrhea, vomiting, and some do get rarely pancreatitis as well. Skin involvement, mainly the rash, and some do get hypermelanosis and chick rash as well. Pulmonary involvement, pneumonia, and ARDS finally. And these patients, due to the hematological system involvement, most of the patients do get leukopenia. You will see the white cell counts around 2000, 3000, or maximum 4000s. And relative thrombocytopenia is also there. Most of the patients shows platelet counts around 140s, but there were patients who dropped the platelets up until up to 70s and 50s as well. So what are the long-term sequelae? So if this fever causes rash, causes arthralgia, and if it goes away, we are not going to bother. But chikungunya, it can cause some long-term sequelae for some patients. So we never know who will be this inverted commas some. So it could be us, it could be some vast majority from our cohort. So therefore, we have to be little vigilant. It can cause chronic arthritis up to 60% of the population at 3 months. So when you are treating also your patient also, you have to say that, okay, I think that you have got chikungunya. So as a long-term sequelae, you may have this persistent joint pain. Otherwise, patients will go here, there, and everywhere just to get relief from their symptoms. And they do get rheumatoid-like illness, later depression, fatigue, sleep disturbances, and all of these things will cause us a reduced quality of life as well. So how to diagnose? According to the WHO and CDC, patients will come with the febrile illness. You have seen the leukopenia and lymphopenia with thrombocytopenia. ESR and CRP will be high because they do get the inflammatory arthropathy. To diagnose, you need the clinical criteria, epidemiological criteria, and the laboratory criteria. There will be possible cases, probable cases, and the confirmed cases. So possible cases, these are the definitions which are given. So therefore, when you are dealing with that, you have to think about, okay, that my patient is confirmed chikungunya or whether this is a probable or possible chikungunya case. So to confirm, you need the laboratory criteria. So viral isolation, detection of the nucleic acid by doing the real-time PCR testing, IgM detection with the serology, and then the positive neutralization test, and fourfold increase in IgG antibodies later. So these are the confirmatory tests, and I think it is available with us, but due to the lack of reagents, our specialists are not in a they are unable to do the testing because of the lack of availability of the reagents. Otherwise, all these facilities are available. So this is the summary of the laboratory diagnosis. So acute phases, because there were some patients who came with this fever and arthralgia, especially who came from Colombo. They carry this chikungunya antibody test as well. So they are really happy that antibodies were negative. But when I asked, when did you do? So it was, they have done it first, second or third day of the illness. So then we know that no point in doing antibody testing in second or third day of the illness. So therefore, you have to advise the patients as well. Otherwise, whenever they goes to the laboratories and they say, I want to get the chikungunya testing done, so they may do the antibody test. That is what happened for the dengue as well in most of the patients, because they are not aware as well. So this shows this zero is the onset of the illness, and when this initial viremic phase starts, and what to do in viremic phase, and when this IgM starts, and when this IgG starts. So therefore, you have to time your testing whenever you are requesting a test for chikungunya patients as well. So these are the updates. So traditionally, you can do the PCR and IgM ELISA. And then recent advances, you have the LAMP test and the multiplex rapid diagnostic tests. I'm not sure whether those are available with us, Tulani. Okay, so that's really good. So if the MRI is, some of them are available at MRI level, so we will be able to discuss with the MRI molecular biology consultants, and then we should be able to get it done as well. So what about the treatment? So once you diagnose your patient is having chikungunya, so it's a viral fever. There is no antiviral agent to treat chikungunya. So mainly the symptomatic management. So you have to advise patient needs good rest and adequate fluid intake. So those are the main two things. And for the pain relieving, initially you have to give paracetamol or acetaminophen, because paracetamol or Panadine also you can give. Those are the two things that we have to give, because there are cases overlap with chikungunya plus dengue. So therefore we cannot advise to give NSAIDs from the beginning. You have to exclude dengue. So once you have excluded co-infection with dengue or just a dengue infection in your patient, you may give. So therefore it is safe to give NSAIDs if your patient is having persistent arthralgia or arthritis after fever subsided and after about 1 week to 10 days time. So then you can safely prescribe NSAIDs. So what is the place for anti-rheumatoid drugs? Usually we use HCQ for severe joint pains. So these patients, some patients need 1 month treatment, some they do need 2 to 3 months treatment as well. And there are some minority of the percentage, some may need even other disease modifying anti-rheumatoid drugs like methotrexate as well, because it can cause deformed arthritis. Like rheumatoid hands, it can cause this deformed arthritis, so you have to prescribe those drugs as well. And what about the newer advances, vaccines? So yes, there are 2 vaccines already developed. So this CHIQ vaccine is the one which is discussing, which is available in US. So this is recommended to give for adults who are above 18 years and adults who are in endemic areas, who are traveling to endemic areas and who are going to stay there for more than 4 or 6 weeks. So it is recommended, but it is not freely available. And for the second vaccine, the vaccine trials are going, so it is not approved by the FDA at the moment. So this was approved in 2023. So therefore, there is a vaccine. I think PG trainees, this is really important. This may appear in your SCQs, so therefore you better know about what are the trials and how it has developed and what will be the efficacy, and for how, what sort of a patients that you will be recommending this vaccine. This is the first vaccine which is approved by the FDA. It demonstrated 98.90 response rate within 28 days post-vaccination. So they have compared it with the placebo, which shows 0%. So therefore, this is really, I would say that it's a good vaccine, which is really effective, but it is not freely available. And then when we are discussing about this sort of like mosquito-borne disorders, we have to discuss about how to prevent and how to control as well. So mainly the avoidance of mosquito bites. So therefore, you have to reduce the transmission. So you have to control the mosquito density. And during outbreaks, it is really important to notify the disease. This chikungunya is not a notifiable disease in your notifiable disease list. But recently, the government has said you have to notify this disease as well, even though it is not in the notifiable disease list. because we have to minimize the outbreaks. Otherwise, if outbreaks are going to continue, there will be so many morbidities which will affect the country's income and rest of the things as well. So therefore, we have to control the outbreaks as well. So this is when we are discussing that, we have to discuss about the reduced mosquito density, reduced mosquito breeding, and reduced mosquito bites as well. So public health and clinical implications, we have to strengthen the surveillance in endemic zones, and we have to recognize atypical and chronic presentations as well. So we may have to include this chikungunya as one of the differential diagnosis once you get a patient with fever, myalgia, arthralgia, and vaccine is available, but it is not readily available. So if it is, if we are going to get recurrent outbreaks, if it is going to be a real burden, we may have to discuss with the authorities regarding the availability of the vaccines as well. So as the healthcare workers, our responsibility is we have to do the fever surveillance in the OPD and even in the ward setting. And whenever you get a patient suspected chikungunya or confirmed chikungunya, we have to inform, we have to notify, and we have to inform the area PHI as well. So then they will do the surveillance. So that is what we have done as well. So then the epidemiology unit and then the provincial directors, they will come to the action. And later on, we have to, even not us, what about the laboratory people, because most of the patients will go to the lab and get the test done, and if it becomes positive, they do not like to get the label. So our patients, they do not like to carry the label of chikungunya as well. They think that it's something bad as well. So therefore, it's the duty of the laboratory people also just to inform that we have got positive chikungunya patients from this area. So those are really necessaries. We have to educate them as well. And then field-based preventive measures we have to do. I have taken this from the Epid unit of Sri Lanka. So we have to strengthen the pre-outbreak preparedness as well as what to do during the acute outbreaks. So primary responsibility is with the community, like involvement of the community departments, PHIs, and rest of the people, epidemiology people as well. Then community outbreak control, you have to control from the household level, institutional level, and the community level. In Colombo, it has seen most of the working places, so not the household level. It was mainly in the working places. So therefore, we have to educate them and tell, because it's that the Aedes mosquito is a day biter, so it's not the night time. So therefore, during working that you can get. So therefore, we have to be vigilant about our work surrounding area during the working time as well. So therefore, we have to control the vector. Social mobilization, surveillance, and communication with relevant authorities are needed. So in summary, so chikungunya is not just a benign fever, even though it is. There are chronic and atypical forms which needed attention. Diagnostics and vaccine brings the hope. So therefore, diagnostics are, if readily available, we have to send our patient samples for the diagnostics, and clinical vigilance and preparedness are essential to control these outbreaks. So these are the references that what I have taken from for these lectures, and that's all.